Okay, in this second chapter, we're going to focus on the biology of platelet-rich fibrin, kind of what the fibrin matrix is, what the growth factors are, what the different cellular activities are, how to separate layers, and we'll go through kind of step by step what we're trying to achieve here. So always remember that when we are using a centrifuge, the whole purpose of using a centrifuge is to separate layers based on their density. So light cells, such as platelets, they're going to go to the top. Heavy cells, such as red blood cells, they're going to go more towards the bottom. And the white blood cells are somewhere in the middle. And when you look at this, you can see actually the white blood cells and red blood cells are very similar in size and in weight. So they're a little bit trickier to separate, whereas the platelets are a lot lighter and smaller, so they can go to the top more effectively. Now, the advantage of platelet-rich fibrin, and as we've reviewed in the written portion of this textbook, is that it's a fibrin matrix. So you get a fibrin clot that forms, and in this clot, you're going to get entrapment of cells, so mainly platelets and leukocytes, as well as different growth factors. And as we reviewed in this chapter, there's many, many different types of growth factors, and of course, they're in many different concentrations. So for instance, there's a lot of platelet-derived growth factor in PRF, and PDGF is the growth factor that's literally derived from platelets. So if you have more platelets, of course, you're going to have more PDGF. Other growth factors, such as BMP2, have been found in blood, but in very, very small, minute levels. So they're not really concentrated. Of course, PRF is not inductive, osteoinductive by any means. Very, very small levels here. So it's important to understand that there are many different types of growth factors in blood, but there's main ones that are obviously more concentrated. And those three that are very useful to explain what PRF is first, there's vascular endothelial growth factor, and that induces angiogenesis. Second, we have PDGF, and that's going to help with cell recruitment. And then we have TGF-beta, and that helps with cell proliferation. And this is one of the reasons why we can use PRF in many fields of medicine or dentistry. Because when you need to revascularize tissues, that's obviously extremely important for the regeneration of any tissue. Whether or not that's your cartilage in your knee, that's typically a very avascular tissue. So if I inject PRP or PRF into somebody's knee, you're going to improve the vascularization of the knee, and then of course it's going to help with regeneration, of course, if I have more blood vessels there. Another aspect, of course, is recruitment of cells, PDGF. And here, there's a big advantage, of course, for any tissue again. Any tissue that's been damaged needs recruitment of cells to the area, and then in the last step here, those cells are going to proliferate. And this becomes very important because depending on how you utilize platelet-rich fibrin will have a big impact on the final results. So if we go over an example very simply, if this is an extraction socket and I place PRF in this extraction socket and I have all bone walls here, well, how does PRF going to help this ridge be maintained? Okay, so number one, it's going to help revascularize the area so you get more blood vessels. Number two, the cells are going to be recruited. What cells are getting recruited? Well, if I have bone walls a little bit everywhere here, these bone cells are going to get recruited into the environment. And then afterwards, these bone cells are going to proliferate. So step by step, they're going to regenerate, and then I'm going to have bone that's going to form thereafter. Okay, so that's how that works. Now, where people get confused and where people get into problems with platelet-rich fibrin is, let's say, for instance, I don't have a buccal surface. If I'm missing this buccal surface, then I have a bit of a problem because now, step number one, I'm going to improve angiogenesis. Step number two, I'm going to get recruitment of cells. Well, if I have bone cells right here, and I have soft tissue cells here, because now I don't have a buccal plate, the soft tissue cells will also get recruited to the area. And then, as we're trying to regenerate this tissue and proliferate, what's going to proliferate faster, the soft tissue cells or the bone cells? And of course, the answer is soft tissue cells. And that's a very important exercise to understand because if you're going to use platelet-rich fibrin, you have to put it somewhere where it makes sense. So example, if you take PRF and you do gingival grafting, if there's no keratinized tissues in the area, you're not going to all of a sudden make keratinocytes, and we'll review that because there's no keratinocytes there. So you can't just magically make keratinized tissue if you don't have the cells there. And those keratinocytes are not found in blood, right? If, for instance, you put PRF in somebody's knee, well, if there's cartilage, of course, how's it going to work? It's going to help, number one, revascularize the tissue. Number two, it's going to help with PDGF, so recruiting cartilage cells, so chondrocytes to the area, and then the chondrocytes are going to proliferate. It will help make cartilage regeneration. So it's very important to understand these steps here because without them, you don't have the understanding of how platelet-rich fibrin actually works, and that's the reason why you can use it in several areas of medicine. So the goal, of course, now is that we understand how these growth factors work. We want to see how we can concentrate these cells, so platelets and leukocytes, as well as growth factors as well that are found in blood. And for that, we use a centrifugation device. Now, this is a very important table right here. You see the density of platelets and the frequency. You see the white blood cells, the density and the frequency, and you see the red blood cells, density and frequency. And the first thing you'll notice, of course, is the platelets are the light guys. Look at the difference in density between white blood cells and red blood cells. Though they're quite close, the main point that I want to make is look at the frequency distribution between these two cell types. 5,000, 5 million. So in every microliter of blood, for every one white blood cell, you have 1,000 red blood cells. And I call that the 1 to 1,000 rule. It means that there's 1,000 times more red blood cells than there are white blood cells. And that means that for every one white blood cell that's down here trying to make it to the top to get platelet-rich fibrin or Lpf, leukocyte and platelet-rich fibrin, there's literally 1,000 red blood cells that are heavier that are coming down. And that little one white blood cell's got to somehow pass through those 1,000 red blood cells to make it to the top layer. And that's one of the reasons why it's a lot more difficult to concentrate white blood cells when compared to, let's say, platelets, for instance, who are easier to get to the top because they're lighter and they're in greater numbers. So a couple of rules here with respect to PRF. Number one, we have to draw fast because we're not going to use anticoagulants, and we'll talk about how much time we have here. You want to start the spin immediately, and you have to make sure that your centrifuge, of course, is balanced. Much like, this is a nice little rule here, pop lids following spin cycle for 5 minutes. Depending on the types of tubes that you use, if you use more hydrophilic tubes, which we'll review later, you will have a clot that forms in the upper layer relatively quickly after the spin cycle. But sometimes, for example, if the patient's on anticoagulants, that clot might not form, it might still be liquid. And one trick that you can do is you can pop the lid and just let it expose to oxygen and wait for 5 minutes or so, and that clot will then form. And there's a reason for that. As in your body, when you have blood, so you have fibrinogen and thrombin that are constantly circulating, you don't have a clot or a fibrin matrix that's forming. When that fibrin clot forms is whenever you cut yourself. So all of a sudden you cut yourself, you start bleeding out, and what happens? A clot forms. Why does that clot form? A lot of it is induced by oxygen. So the oxygen actually helps the fibrinogen plus thrombin to fibrin, and that's how you get the clot. So the same thing applies here with these tubes. If you simply pop the lids and wait a little while, that with the oxygen will clot a little bit faster. So when we make the membranes, okay, or when we make the clots, it's a good idea to pop the lids, okay, and you can use them thereafter. When you actually are trying to do the opposite and you're trying to keep it liquid longer, that's when you don't want to pop the lids, because if you do, it's going to clot faster. And because you want to use this as a liquid injectable in some minutes in the future, always make sure to keep this liquid with its lid on top. And we'll review this a little bit later in different chapters. So again, the tubes themselves are quite important. And the tubes are so important, in fact, they're an entire chapter on their own in chapter number 6. Here what we're doing with the tubes is, if we want to make a tube that's going to induce a clot, it's a lot like dental implant surfaces. So if this is a titanium implant surface, and this is a platelet, the more hydrophilic this titanium implant is, and you've seen that today with more hydrophilic implant surfaces, so the SLA versus SLA active, or all of the Nobel active surfaces, if it's more hydrophilic, it's more water loving. If this is a platelet, he's going to be more attracted to this actual surface, this water-loving surface. And then he can bind, releases growth factors, clot then forms, and then typically osseointegration will occur a little bit faster. And you've seen the nice videos where they take a titanium implant, they dip them into blood, and sometimes you'll actually see the blood will actually rush up the actual implant surface. And you've even seen some videos, there's some great ones, where they take an implant surface with a very hydrophilic surface, they dip it in blood, And then as they raise the implant out, you can actually see the blood is already clotted and it's actually pulling the blood. The implant's pulling the whole blood clot up all together in a few minutes. So it's quite interesting, that whole field and what they're doing there. And that's based on science. The more hydrophilic, the more water-loving, the more the platelet will be attracted, the more he binds, and then of course, release of growth factors and a clot then forms. The same is true for pure F tubes. If you have a pure F tube that's more hydrophilic, then that same platelet is more attracted to it, can bind to it, and then clot forms a little bit faster. And that's what we're trying to do with tubes. So the red top tubes, you make them more hydrophilic. If you make them more hydrophilic, they're better, and that's going to make a better clot. So that's step number one. And the tubes matter a lot. Okay, the tubes matter, I would say, a lot more than centrifuges do. On the other end of the spectrum, with the white tubes or orange tubes or blue tubes or green tubes, whatever, the concept here is that if you want a liquid pure F tube, the more hydrophobic, okay, the more it's going to push the cells away. So this platelet wants to bind and make a clot, but if it's a hydrophobic surface, it's going to push the water, and then that platelet can't bind, and then it stays liquid longer. So the more hydrophilic I make it, the more it will form a clot. The more hydrophobic I make that surface, the more it's going to stay liquid. Okay, so very important point there. Of course, with these centrifugation devices, they have to be balanced. Okay, this is a no-brainer, but I like to review it. And I'm just going to talk about kind of the most common mistake that people make. Of course, you can't do stuff like this. But we often get questions after courses, where people are doing such things like this. This is obviously not a centrifuge that's balanced. If the centrifuge isn't balanced, it will not generate platelet-rich fibrin and separate layers effectively. Remember that these are devices that are spinning at very high G forces. And so if they're not properly, balanced per se, there's going to be major issues here. Okay, of course, with the white tubes, you always have to make sure white tubes are balanced with white tubes, red tubes are balanced with red tubes. Sometimes the red tubes are made out of glass and they are heavier than white tubes. And if you try and balance a red tube with a white tube, this will not work. Okay, so that's an important little point here. Make sure the red tubes are balanced with the red ones, white ones are balanced with the white ones, and ideally, like I said, blood levels should be filled roughly to the same levels. Okay, I just wanted to cover that very, very quickly. Now, when we talk about kind of the background of platelet-rich fibrin, we're going to use PureF for many different indications. And as we've seen in the textbook, the first edition here, it can be utilized to soak barrier membranes, can be made sticky bone. There's many, many different things that you can do here. And so we're going to go over a few of these small videos here. So this is a platelet-rich fibrin clot that's been removed. And in these, a few things that are important here. Okay, so number one, you can see that the lids are already popped and I've waited for 5 minutes. When I remove these, always remember that as you spin and the faster you spin, the more the cells are going to the bottom of these tubes, right? So if there's more cells in a PureF clot, most of the cells are found at the very, very bottom of this clot. So the last thing you want to do is actually to pull out one of these PureF clots and actually cut at the very base of this PureF membrane, because that's actually where the majority of the cells are. Okay, so as we remove them here, we just go through, and it's very easy to draw, like I said, you can draw as much theoretically as 30 tubes. So when you go to a blood bank, always remember that you're going to give, typically on a weekly basis, you can give 300 mLs of blood, and that's the equivalent of 30 tubes. You're never going to take 30 tubes from a patient. So never worry by taking, 6 of these tubes or 10 of these tubes. That's not really an issue. Now here, there's different things that we can do now with platelet-rich fibrin. So one of the things we can do is make PureF plugs. So here what we're doing is we're going to take a couple of these membranes and we're going to place them in these little cylinders, and then there's a little piston. And what we're essentially trying to do here is we're trying to compress the platelet-rich fibrin, so to take cells from a large volume and basically compress them down to a smaller volume where they're more concentrated. Then you can remove these, and we're going to place them on the tray here just to see what they look like. So now you can see that that full-size clot is, of course, much smaller. Okay, so it's condensed and it's very densely packed there. So that's one thing that you can do with platelet-rich fibrin. Another thing that's commonly done is you take the trays and you actually compress them. So you leave them there, and as they sit there, they're going to compress, so you're going to get actual compression of and make membranes. So this is to make PRF membranes. Once this is done, of course, you can lift this up. Always make sure that you see that the membranes are not stuck on the top of the actual tray. So make sure in these cases here, one of the things that happens frequently is that the PRF membranes will actually stick on the upper portion of these trays, and then you'll pick this up and actually put it down and waste one of your membranes or two of them. So make sure they're there. Now you can see that I'm taking them out, and of course I'm just going to lay them down here. Okay, so that's how you make the PRF membranes. Okay, so here we're going to actually draw some liquid platelet-rich fibrin. So as you can see from the video here, when you're drawing liquid PRF, the lid is on. And the reason why, of course, is because we do not want oxygen to necessarily get incorporated in here. So the needle will go in through the lid, and then you're going to draw up the liquid platelet-rich fibrin. Okay, so then we can draw this up, and that's the way that we're typically going to do this. Okay, once that's done, and we'll review, what to take. You'll talk about the layers, because of course, near that red Buffy coat zone is where most of the cells are. And we'll talk about kind of the science behind how to draw up this liquid PRF. So in this video here, what you see is the same thing just from a different angle. And you can see most of the cells are located at the base here. So in this video here, we're going to enter again the needle, and then we're going to draw up again through the lid, and then you're going to take out the liquid platelet-rich fibrin. Again, trying to get that needle close to that Buffy coat zone at the base there. Okay, and that's the way to draw up the liquid platelet-rich fibrin. And we'll speak more exactly why we're doing this procedure here. Okay, so that's the final result. And again, there may be a few red blood cells in there. In the facial aesthetic field, you need to be a little bit careful with the red blood cells, but generally speaking, not a big issue. There's a lot of platelets and leukocytes that are found within that red Buffy coat zone.
Grab two of these membranes.
When we actually want to make the sticky bone, one thing that we do is we first cut up the PRF membranes into fragments. So you'll see here, 2 PRF membranes. We're going to cut them up. Okay, so here we are cutting. And this procedure, you can make sticky bone probably in about a minute. And we'll review in the clinical chapters, the effect here of platelet-rich fibrin, specifically on bone, is relatively limited. So the bone induction or osteoinduction is not present from platelet-rich fibrin, but it does improve the handling of these grafting materials. So in the literature, it's been shown that it improves angiogenesis, of course, and this is important as well for bone formation. However, its direct effect on making ectopic bone or such things, is not present. The real advantage of mixing PRF with these bone grafting materials is the handling properties. So you'll see here, of course, this is a large bone graft that I'm mixing here with several cc's. I'll add the liquid platelet-rich fibrin here, and I didn't have enough, so I'll go to another tube. Always remember you're going to draw from the lid, so you're going to pull out liquid platelet-rich fibrin from the lid, through the lid, and then afterwards we're going to mix it, and this is the final result that you're typically going to get. So in this case here, you'll notice that the sticky bone that's fabricated is a lot more densely packed, number one, and it's got great handling properties. So that's the grafting material that's been fabricated. This is something that you can then take to a GBR procedure or a sinus grafting procedure, and you'll have much better handling properties here. Okay, so there's a real advantage there. Okay, so when we talk about leukocytes, white blood cells are extremely important. I could honestly speak for probably about an hour on the importance of white blood cells. For those that want to learn more about how important leukocytes are, in particular around biomaterials, you can read a paper that I wrote with Dr. Dieter Bossart. And together we talked about osteomacs. So these are osteomacrophages, the white blood cells, and how they're key players around bone biomaterials. So with this concept in mind, we're really trying to see how many white blood cells we can incorporate into platelet-rich fibrin. And one of the things that was shown by Dr. Ganazzi, again, that was reviewed in the first chapter, was the fact that when you spin fast, all the cells go to the bottom of the tube or right at the Buffy coat zone. So they're not evenly distributed in this upper layer where platelet-rich fibrin is taken, and the majority of the cells are either found right here at the Buffy coat zone, or even worse, all the way at the base of this tube. So our group in Bern, Switzerland, and this is an intro to Misako Kobayashi, who's one of the biological editors of the book. She's done a lot of great studies on platelet-rich fibrin over the years, and one of them has been looking at the release of growth factors over time. So when you look at this graph here, you see TGF-beta, you see the time from 15 minutes all the way up to 10 days, and look at the growth factor release at 10 days for Lpf, so the original protocols. That's fast, okay, for a lengthy period of time, so 12 minutes. This is slower speed, this is slower speed, and slower time. And in these cases here, like I said, you can really see a lot more growth factors that are released, up to 4 times more. This is the same person's blood, okay, everything's the same machine, same tubes, only difference is the protocols. And that's one of the reasons why we always say that protocols are extremely important when you're trying to produce platelet-rich fibrin here. And again, just to review some of his work, here's the standard protocols, Lpf, big membrane. As you spin slower, okay, you get a smaller membrane, and if you go slower with less time, even smaller. But look at the difference in growth factor release here. You get a lot more growth factors here, a lot more growth factors in cells, sorry. So here's the leukocytes, a lot more leukocytes, a lot more growth factors, okay? And so from a clinical point of view, it was much more effective to take, 2 vials of APRF plus, which have up to 4 times more cells and growth factors when compared to one of the original protocols, which is not able to maintain all of the cells because you're spinning so fast that the majority of the cells are going to the bottom of these tubes here. And we were actually interested to better understand platelet-rich fibrin. And this was a study that was done in 2018 with a young student. Her name was Anika Dam. And the goal of this study was to figure out why there's so much variability in the population. So simply put, clinicians were always saying, well, sometimes I would spin blood and out of 6 tubes, 2 of them were small membranes and I had some big ones. And how come there's variability there? How come there's variability as well in the population? And so Anika set out to do the study with myself and a few other colleagues here to look at the effect of age, gender, and time between the start of when you're doing a blood draw to whenever you actually put it in the machine and you start spinning. So simply put, what we were trying to figure out is there amount of time that's required between when you do this blood draw to when you actually get it in the centrifugation device. And the way we did it is we took one volunteer, for instance, draw the blood, start spinning right away after 0 seconds. Second tube of blood, start spinning after 30 seconds. Third tube of blood, 60 seconds, 90 seconds, a minute 20. And then we checked the size of the membranes over time. So it was a quite interesting study that we had done. Anika drew 300 samples. Okay, so there was 300 different samples that were drawn to get to this data where she looked at the average size of the PRF membranes here. And by 60 seconds, it was 6% smaller. By 90 seconds, it's 13% smaller. By 120 seconds, it's 23% smaller. So you see here, there's significant reduction in the membrane size, especially at 120 seconds. So we always say, 2 minutes, 23% smaller membrane. But even more importantly, imagine what happens. When you're spinning, always remember that if that tube of blood, this is a red tube, okay, it's going to induce clotting. So if it sits there for 120 seconds, that's 2 minutes. During that 2 minutes, the fibrinogen and thrombin are slowly getting converted into fibrin. So you're starting to make this fibrin matrix in this tube. And then when you put it in a centrifuge and you're trying to spin and separate the layers, the cells can't separate as effectively because a lot of these cells are actually getting trapped in this fibrin clot, okay, that's already starting to form. So ideally, like I said, we always say probably in a perfect world, 60 seconds, at most 90 seconds. And then importantly, it takes about 15 seconds to draw up one tube. So we always say, between 4 to 6 tubes. 6 tubes is really the maximum that you can draw before starting to spin. Now the next question, if you're going to draw for sticky bone and you're going to draw white tubes and red tubes, okay, which tubes are you going to draw first? And I always tell colleagues, just think about this logically. If you're going to draw white tubes first, then that white tube is going to sit there And now I'm going to draw the second tube, the third, fourth, fifth, sixth tubes. So I draw 6 tubes. Which tube would I rather have sitting there the longest? Would I want to have a hydrophobic tube, or would I rather have a hydrophilic tube? And the answer is the hydrophobic tube. Because if I have that plastic tube, the white tube or the blue tube, etc., and it's sitting there for 60 seconds or a minute and a half, that tube is not going to induce clotting. So it's still liquidy. And then I can put it in the centrifuge and separate layers. If on the other hand I drew that red tube first, that red tube is going to start clotting, and then when I put it in the centrifuge, it's harder to separate the layers. Okay, so again, little pearl there, always draw the white tubes or the plastic tubes, the blue tubes, whatever color they are, first. Okay, and ideally in a perfect world, blood draw should be achieved within 90 seconds here. Okay, so who makes bigger membranes, males or females? And that's an interesting question, and it's actually very biological. So in general, females make bigger membranes. And when we look at the data, you can see here that the females, whether they're drawn at 0 seconds all the way up to 120 seconds, always produce bigger membrane. And the reason why is because the normal hematocrit counts for men is 40 to 54%, whereas for women it's 36 to 48%. So on average, okay, based on the data from these 300 samples, 17% larger membranes are found in females. Okay, quite interesting. And that's just related to the hematocrit counts. So simply put, if you have more red blood cells, as men do, their blood is thicker. And if their blood is thicker, when you put it in a centrifuge and you try and separate the layers, it's a little bit harder to separate. And for that reason, the membranes turn out a little bit smaller. And the same thing is true in older patients. So in older patients, when we look at the average size of PRF membranes, you can see here that there's really a big difference here between an old patient of 61 to 80 years old or a young person that's 21 to 40. Okay, there's about another 20% difference there. So who makes the biggest membranes? The answer is old females. Who makes the smallest membranes? And that's young males. Okay, as well as, let's say, for example, you're an athlete. Athletes carry more oxygen, have more red blood cells. In those cases, those patients will typically have smaller membranes. Same thing if you live at high altitude, right? If you live in one of these high altitude cities, well, high altitude, low oxygen, more red blood cells. Bigger hematocrit counts, harder to separate the layers. So your protocols, they may need to be adjusted dependent on where you live. So if you live at high altitudes, of course, you may need to spin a little bit faster to get better separation of your layers, as well as in younger males. So for instance, if we have a 16-year-old male athlete that comes in and he's getting his third molars extracted, you might consider pumping up the protocols and add an extra 20% of G-force simply to get the right size membrane that you're looking for. Okay, and that's the biology behind that. So it's not to say that every single person that comes in, you're going to change protocols, but I want people to understand why sometimes you get these bigger membranes and other times the membranes are a little bit smaller. So in summary here, a longer delay from the time that you start will result in smaller membranes. You want to do this within 90 seconds. By 120 seconds, like I said, it's significantly reduced to the point where probably the cell quantification inside of these after 2 minutes is greatly reduced. Females make bigger membranes, as do old patients. Okay, so that's a summary there. Now there's a lot of commercial debate in this field, right? There's a lot of competition between centrifugation companies, etc. And when you look at centrifuges, really there's two types. There's fixed angle and there's horizontal. And of course, we'll review there's advantages of horizontal. But after that, the difference between one machine to the next, is there a difference in quality? Yes, if you buy a better quality centrifugation system, you will get slightly better results. But more importantly are the protocols. Okay, you want to be able to use a protocol that makes sense. Because you're separating cells based on density, it's very important to make sure that your protocols are optimized to make sure that if you're going to draw that patient's blood, right, and you're going to go through all that process, make sure that you use a protocol that's really designed. And what we did in a study was we said, the 3 most commonly utilized centrifugation systems in the United States are the Salvin system, the Duo Quattro by Chacrun here, and the Intraspin machine. And of course, the original protocols, the LPRF, which were too fast by Intraspin, as well as the more concentrated forms in the APRF from Professor Ganati's work, we said, well, it really doesn't make a difference between which machine you're going to use here. But more importantly, we wanted to optimize the centrifugation devices so that if you were a clinician and you happen to have a solvent system, it didn't mean that you had to go out and buy a different machine. It just meant that you had to program that machine properly. And one of the chapters in this textbook is going to look at how to calculate G-forces, okay? And I think it's an important one. Now, when we actually look at the effect of G-forces, when we do these studies, we want to make them as standardized as possible. So we'll take one person's blood, and every individual will donate blood, and they'll go into the machines. Like I said, you can take 30 tubes of blood from a person, so taking 12 tubes, for instance, to do a study, or 18 tubes, is really not an issue here. I did a lot of this work with Yufeng Zhang, so I wanted to give him credit as well. Yufeng and I had written the textbook Next Generation Biomaterials. He worked in Bern, Switzerland with our team for a number of months, and we've continued to do work together for years and have resulted in more than 100 publications. And so he and I set out to calculate, with the help of some engineers, the sizes of these devices. When you actually want to know the difference between companies, basically at the fundamental level, what you're going to calculate is the G-force. And you can take the RCF values, which stands for basically G-force, from the minimum of the tube, the clot, or the max, okay? And there's different angulations here of the devices, and there's different RCF max that you see here. Now, why is this important? And why should you never care about the actual RPMs, okay? When you have an actual centrifugation device, let's say, for instance, that I start spinning in a very small circle at 1 rotation per second, okay? There's a certain amount of G-force that's produced here. But if this radius is increased, what happens? Even if I'm going at 1 rotation per second, of course, you're going a lot faster way out here, and there's a lot more G-force. So to report RPM is not really an effective way to do this. Actually, what you want to do is report G-forces. And it doesn't mean that if your machine is this big and you're spinning at 1,000 RPM, you can't take a machine that's this big and spin at 1,000 RPM and consider it the same. There's a big difference between the G-force that will be produced here versus here. Now, it doesn't mean that you can't take, for example, if I say to you, I'm spinning at 1,000 RPM on a machine this size, if my machine is this big, it might just mean that I have to spin at maybe 500 RPM, and then I get the exact same G-force at the end. And that's what we've done in this publication to calculate what the G-forces should be in all of these scenarios here. So this is the title of that publication, Comparison of Platelet-Rich Fibrin, produced using 3 commercially available centrifuges at both high and low G-forces here. So when we did this study, we learned a few things that were very, very important. And the most important thing that we found was that the biggest difference between the companies were in fact the tubes, not the machine, the tubes. And that's when we learned that the tubes are actually critical for the proper fabrication of platelet-rich fibrin. So the way that these studies were being conducted was that we were drawing blood, and we were drawing the tubes from every company. So we wanted to standardize. We said, okay, in the intraspin machine, we're going to use intraspin tubes. In the Salvin machine, we're going to use Salvin tubes, so on and so forth. And then we started to realize that even though our G-forces were properly calculated, some sets of tubes always generated bigger membranes, others always generated small membranes. And so what you see here is the same person's blood. So let's say you take my blood. You spin my blood, different tubes, so we draw them in a random order, put them in the machine, and then spin with the same person's blood, same machine, same protocol, everything's the same. The only difference is the tubes. And now all of a sudden, I'm seeing that the membranes that are coming out are different sizes. But it's the same G-force, it's the same machine, everything's the same. So we looked at this and we said, wow, that's pretty interesting. So we then said, let's do a study just on the tubes. And the way that you want to standardize this is we said, we're going to take 2 tubes. So this can be the Lpf tubes, the APRF tubes, and the Salvin tubes. 2 tubes from each company, and we're going to draw them up in a random order. So there's 6 tubes here, 3 from each company, drawn up, and then put them all in one machine. And then we're going to see what happens with the size outcomes. And we did this for the 3 different devices. So 6 tubes went in the Salvin machine, 6 tubes went into the Duo Quattro, 6 tubes went into the Intralock machine here, 18 tubes, again, perfectly fine. And then we did our investigation. And in this study here, it was very interesting. So what you can see here in this image here, the top is the Intralock machine. So the top is Intralock, 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 Chacrun, Chacrun, Chacrun machine, Salvin machine. And then the little letter here represents the tube. So here the I is the intraspin tubes, here the C is the Chacrun tubes, and here the S is the Salvin tubes. And what we learned is that, look at how small these intralock tubes are versus these guys, much bigger. Same thing here. Even if I use the Chacrun machine, the intraspin tubes generated these small little clots in comparison to some of the other ones. And what we learned was, in fact, that the tubes matter a lot. And that's really a key finding in this publication that was done in 2018. Now, when you look at this, here's the intraspin machine, process for pure F machine, Salvin dental machine. Here's the intraspin tube, process for pure F tube, and Salvin tube. And you notice that no matter which machine you spun on, the intraspin tube is always the smallest, the process for pure F tube is always the largest, okay? And the Salvin is somewhere in between both. So very interesting finding. This is the same data, intraspin tube, process for pure F tube, Salvin dental tube. Again, look at the tubes. Doesn't matter which machine you use, the intraspin tube is always the smallest, the process for pure F is always the largest here. And what was even more surprising was the best results were achieved in the intraspin machine with the process for pure F tube, okay? That's a huge increase here. So that's the best result, huge increase, as I mean, compared to this right here. And so what we found is that the difference between the machines is very minor, 15, 20%. Difference between the tubes, more than 200%, okay? The tubes are critical, and there's a full chapter that's dedicated to how important these tubes are, of course. Okay, so now that we know that the importance of the tubes, how important these tubes are, our group started realizing it's not optimized. The tubes are not optimized, as well as the centrifugation device. So we were actually asked to develop a system for platelet-rich fibrin and try and advance the field as much as we could. And this publication here is probably one of the most relevant research articles that our group has written. And it was titled, "A Novel Method for Evaluating and Quantifying Cell Types in Platelet-Rich Fibrin and an Introduction to Horizontal Centrifugation." And one of the things that we wanted to do here is we said, let's figure out a better way to actually quantify the platelets. And I'll show you the issue that we have in the literature. One of the things that you see commonly is that whenever you want to quantify platelets, the way that a lot of researchers will do this is they spin, separate the layers, you draw out the plasma layer, and then this plasma layer, you'll then quantify how many platelets and leukocytes you have here. And when you look at this, you say, okay, I'm 3 times more concentrated in platelets when compared to whole blood baseline. So you take a CBCT of baseline, of baseline, as well as a CBC after concentrating. The problem with this technique is the following. When you look at some of the Lpf protocols, and as you've seen from Dr. Ganazzi's work, a lot of the cells, when you spin fast, bunch up either at the Buffy coat zone or in the red zone. So here you see here, they're all bunched up. But when you draw this out and you draw out all the plasma and you go to quantify this, it actually doesn't look too bad here. Okay, this is decent. Now you have an average of this, but it's not representative of what's actually going on in the tube. So if you were actually to take this membrane, ideally if you take this membrane and you lay it down, you want to have cells evenly distributed throughout this pure F clot. But the problem is that all of the cells are bunched at the bottom. You use this method here, and it looks like it's decently concentrated. When you compare this to the Lpf protocols, now you have a better even distribution of these cells. But the problem is when you draw this out and you compare this to this might be only 20-30% better than this, okay, which has been shown. But the main issue between these two here is that this has even distribution of cells, and again, this one here, all the cells are just bunched up at the Buffy coat zone. So like I said, if you're going to do a GBR procedure and you open, this flap, and then you want to lay your PRF membrane down here, well, the problem is you have lots of cells bunched up here, and you don't have any regenerative potential up here in that membrane. okay? And that's one of the issues that we see with these faster protocols. So we developed a new protocol, and like I said, it's probably some of our most impactful papers in research, because now what we've done is, instead of taking the full CBC and analyzing how many platelets, etc., we said, you know what, let's divide this tube into 10 different layers, and every single one of these layers we're going to send for CBC analysis, and we're going to get platelets and leukocytes in every single one of these layers, okay? This way here, you can't basically fool the system. If there's no platelets in this first layer, you send that first layer only, and you do pipetting method, so it's very accurate. First layer goes to the CBC, how many platelets, how many leukocytes, and if there's none in there, you know, you basically can't fool the system. So when we do it, like I said, we use a pipette and we go all the way down. So one layer at a time, 1 ml at a time. Always remember that there's one layer where you're going to get a little bit of the plasma and some of the red zone. So one of these layers will have, and that's called the Buffy coat zone, and that's a very important zone because that's where you'll find a lot of the cells, and I'll explain this in a few slides. Then we go 6, 7, 8, 9, 10 all the way down in the red zone. So let's look at some of the data. If we spin in the intraspin machine at 2700 RPM for 12 minutes, okay, so this is their standard protocol to produce Lpf. This is the method that we use, and you'll see here it's very accurate. Okay, so it's very accurate, like I said. It's so accurate, in fact, that whenever you take that fifth layer, for instance, you can actually still see the plasma and the red zone that's separated. And when you look at all the test tubes here, 1, 2, 3, 4, the plasma here in the fifth layer, as well as the red zone, 6, 7, 8, 9, 10, all the way down. Okay, so send this to the CBC. Look at the data. So this is the Lpf protocol. Number of leukocytes, number of platelets, number of lymphocytes, number of red blood cells, number of neutrophils, number of monocytes here. When we look, for instance, at the red blood cells, the way that the data is addressed is, this is the top layer, 1, 2, 3, 4. This is that fifth Buffy coat layer, 6, 7, 8, 9, 10. This is the whole, okay? This is the average from the whole blood, okay? Not spun. So this is the average, and you can see the red blood cells, they get concentrated in layers 6 downwards, and there's a little bit in that fifth zone, of course, because that fifth zone had a little bit of the plasma and a little bit of the red. Look at the number of platelets, all concentrated in that fifth layer. These top layers don't have any platelets here. Look at the leukocytes, even worse. They're a little bit heavier. Nothing in the top 4 layers. There's some in the fifth layer, and then majority are in the red zone, exactly as Dr. Ganazzi had shown histologically. But again, the moral here and the point and the message is, you spun too fast. You spun so fast that most of these cells didn't end up evenly distributed in these upper layers here. If we look at the slower speed, slower time, now you can have a more even distribution of these platelets. But one thing that was interesting by using this method was that even though you use this method, and this is the right protocol to use, let's say, on a fixed angled centrifuge, the leukocytes were not being gathered in this upper layer. They were still stuck in the bottom here. And that was a little bit of an issue here. Okay. Why did this occur? We'll review this in a couple slides as a result of using a fixed angled centrifuge. Okay. And so a lot of work was done here, but if you do have a fixed angled centrifuge, always remember that these slower speeds and slower times will get a better distribution of these platelets when compared to using these faster speeds, okay? So there's a difference there between this and this. So again, if we go to the publication as a summary, the difference here is the Lpf protocols, and again, the RPMs don't matter so much, focus on the G-forces, all stuck here, whereas the slower speeds, and this is typically around 200 Gs for 8 minutes, more even distribution of cells here, okay? So that's an advantage here by using those protocols, and that's been now shown in a number of studies. The next thing that we wanted to address is, we said, you know, this fifth layer has all of the cells. Okay, majority of platelets are here, a lot of the leukocytes are there, but this fifth layer is half plasma and half red. I wonder where these cells are. Are they actually in the plasma, or are they actually in the red zone? And when you do this investigation, and again, you can just send for CBC, this is the control. This is the number of leukocytes, number of red blood cells again. The control, you can see here, all of the red blood cells, I should say, are in the red zone. Okay, that just makes sense. There's no red blood cells here in the plasma. But look at the platelets. You got more platelets in the yellow zone, which makes sense, but you also have some in this red zone, and quite a lot of them. When you look at the white cells, the leukocytes, you actually have more in the red zone than you do in the plasma zone. So there's a lot of these leukocytes that are hanging out right here. And that makes sense when you look at this original graph. If you look here, there's more white blood cells, in this red zone. Okay? So it makes sense that there's actually more of the leukocytes that are found here. Why am I telling you this, and why is it very clinically relevant? When you want to draw liquid platelet-rich fibrin, always remember that the majority of the cells are actually found, right at the Buffy coat zone, and also some of them are found in that red zone. So there was this publication that was published by a group in Bangkok, Influence of Fractionation Methods on Physical and Biological Properties of Injectable Platelet-Rich Fibrin. And here, what they did was they compared two fractions of IPRF. There was the yellow fraction, harvested only the upper yellow layer, and the red fraction was collected both the yellow and then a little bit of that red Buffy coat zone. And what they found, which makes a lot of sense now that we have more data, at day 7 and 14, PDGF concentrations were statistically significantly higher in the red IPRF group. Okay, so I remember seeing this paper, and it was published in 2019, and it was titled Injectable Platelet-Rich Fibrin, Cell Content, Morphological and Protein Characterization. And in this study, one of the goals was to look at IPRF and really to characterize it. And I remember reading this and was paying particular attention to some of the figures, because they were comparing leukocytes in blood versus IPRF, and they found that there was only a marginal improvement in leukocytes, only about 30–40% more than whole blood, which isn't a lot, as well as platelets only being about 50% increased. So it was very, very minor using the IPRF protocols. And I remember looking at this and thinking to myself, wow, that's not really a big improvement here. And when they actually looked at some of the growth factors, they actually found that whole blood sometimes released more growth factors than the IPRF. And it was a little bit shocking for me to read this paper. And I remember going back to our study from 2017 and looking at it a little bit more critically. And of course, you're always trying in research to try and optimize things as much as possible for the field. And this study here, titled Injectable Platelet-Rich Fibrin, Opportunities in Regenerative Dentistry, was written by myself as well as Misako Kobayashi, as well as a few other colleagues here, Dr. Hernandez and Dr. Candelam, Yufeng Zhang, so my colleague from China, Dr. Shyam Ganatsi, of course, one of the pioneers in the low-speed concept, as well as Joseph Chakroun. And in the study, when we published it, of course, we found that cell migration was improved using IPRF when compared to PRP. But we also sometimes found that PRP performed better in some experiments. So here you can see PRP was better than IPRF. And I remember thinking to myself, at the time, I wonder why this was occurring. And it was something that was discussed amongst some colleagues. So again, here you see PDGF concentrations being improved with the IPRF group. The collagen especially was improved in the IPRF group, and I attribute a lot of this to be able to form the fibrin clot. So by having that extracellular matrix protein in the scaffold, of course you can get better collagen synthesis, etc. But the growth factors in PRP was actually better than it was in IPRF, and that was over the 10-day period. And I remember at the time, it was hard to understand why. And now that we've seen this paper in 2019 by a completely other group, I looked at it and I say, you know what? The platelets are not being concentrated enough. And when we now used our novel method for harvesting platelet-rich fibrin, now, like I said, two things that are important here. Number one, always make sure that you're going to draw all the way up to the red zone here. So you'll see here in the video, we're going to draw the blood and it's going to go right to that red zone layer. But more importantly, when we actually looked at the cell types and the separation of layers, look at layer 1 and 2. So we know IPRF is typically only about 1 cc of blood, 1.5. And look at the number of leukocytes. They're hardly concentrated. Look at the number of platelets. So we only have about a 2-fold increase here. Look at how many platelets are still in the red zone. Look at how many of the white blood cells are still in the red zone. They're not actually making it to this upper layer. And so what we learned from some of these studies was that, in fact, you can spin so slow that you don't actually concentrate the cells properly in the upper layer. And that's one of the reasons why that our paper from 2017 didn't show as much optimization as we could with respect to the growth factor release when compared to PRP. And as well, the other group showed that, in fact, there's only marginal improvements. Now that we have this technique here, there's a big advantage because now we can look very specifically layer by layer by layer where the cells are going. And this allowed us to actually further develop concentrated platelet-rich fibrin, which is a liquid formulation of PureF that's a lot more concentrated when compared to these original IPRF protocols here. Okay, here what we see here is a real-life image of platelets, leukocytes, and red blood cells. And it goes to show you the size difference between the different cell types. So here you can see the platelets, these are the little guys. Red blood cells are the big guys. White blood cells are the big guys as well. Platelets can more easily be separated based on their size difference, but when you look at white blood cells and you look at red blood cells, you can really see that they're very similar in size as well as very similar in density. So they're actually, in fact, a lot harder to separate white blood cells from the red blood cells. And when you want to separate layers, like I said, it's based on their density, and we're using a centrifuge for this. Always remember that cell separation or density separation occurs in a centrifuge based on the difference between the RCF min and the RCF max. So when you spin on a fixed angle centrifuge, that difference isn't maximized like it is on a horizontal centrifuge. So as you can see here, there's really a big difference in the ability to separate layers because on a horizontal, the advantage is that you can really get a bigger G-force here at the bottom of the tube. So that's advantage number one. But more importantly, what I want you to think about is when you're a red blood cell, and let's say you start up here on the tube, when you start spinning fast, the cell goes boom against the back, and then because he's a heavy cell, he's going to start going downward, so he's going down the tube. If you're a little platelet and you start down here, you start and you spin fast, so you go to the back of the tube, and then you have to start climbing up this hill, okay? And you're climbing up as all of the red blood cells are coming down along the back wall here. So it's very difficult for that little platelet to get through, and even harder for that white blood cell to do so because he's very similar in size with these red blood cells. And of course, there's that 1 to 1,000 rule that we spoke about earlier. When you go on a horizontal centrifuge, the advantage here is that that little platelet that starts here, he can very easily make it to the upper portion of the tube because he's just got to basically go horizontally across this tube as opposed to on a fixed angle, he's got to climb up the tube to the top. And that's one of the advantages of spinning on a horizontal centrifuge. Now, for those that have never seen that, that's what the BioPureF system is. So when these tubes going up and down, like I said, you can see here very clearly, tube goes in up and down, and then he swings out. So it's called a swing out bucket, and it's basically going to go completely horizontally during the spin cycle. Okay, so that's a more effective way to separate layers based on their density. So again, advantage number one, of course, you can maximize the G-force difference between the RCF min and a max. So that's one big advantage. And when we want to calculate G-forces, this is more for biologists or scientists. When you have a fixed G-force that you want to produce at the clot, the real advantage of going horizontal here is that instead of being at a G-force of, let's say, 400 G at the max here on a fixed angle centrifuge, when you go horizontally, that 200 G at the clot is not 400 G anymore. It's now 700 G, or it's greater. And what happens now is that these red blood cells, they get pulled down to the bottom of the tubes much more effectively on a horizontal centrifuge. So when you look at the difference here again, that G-force gradient difference between the min and the max is really maximized when this tube is horizontally. For those that have seen on a fixed angle centrifuge, kind of this angulation here when you're spinning platelet-rich fibrin, that's a result of going fixed angle. If you go horizontal, you get a clean separation. And the advantage of having this clean separation now is, of course, it's much easier to separate the layers. But more importantly, like I said, the cells are not getting banged up on the back walls here. They're really separating horizontally. So that's what a horizontal centrifuge separation looks like versus a fixed angle. And this is the big one. Like I said, this is probably one of the most important figures that we've been able to generate our team. When we go fixed angle, all the cells go to the back, and then they have to separate back here on this back wall, and we'll look at some studies that have evaluated this. When you go horizontally, these cells can just free pass. So a little platelet that's at the bottom here, he can free pass to this upper layer, whereas over here, a little platelet that starts down here quickly gets sent to the back, and then he's got to climb up this mountain when all those red blood cells are coming down. And especially for white blood cells, it's very, very difficult to separate those layers. For those that have seen these little red dots here after you spin, so when you spin on a fixed angle centrifuge, you'll often see this. And if you look at a little video here, you see all these little red dots, and they're only found on the back. That's a result on a fixed angle. All those cells are basically getting jammed back there on that back wall. And it's not just up here that you see these red dots. If you look in the tube, they're all the way down. And so if you're that little platelet that starts at the bottom here, you have to somehow make your way up to the top layer where all these cells have basically smashed on this back surface here and try and make it to the upper portion. Now, the 1 to 1,000 rule, and how important is that? Think of the frequency distribution here. The white blood cells and the red blood cells, as we've seen, very similar in size. The frequency distribution, 5,000 versus 5 million. So there's, for every one of those white blood cells that's trying to make it to the top, there's 1,000 red blood cells that are coming down. And that's one of the reasons why it's very difficult to separate these layers, okay? So again, that little white blood cell or platelet that's down here is having a very difficult time to try and make it to this upper portion. And it's not something that you can see visibly with your eyes. Like I say, the nice thing with platelet-rich fibrin is you can see the little red dots on the back tube. So if you do have a fixed angle centrifuge, have a look back there next time you spin. You'll see a little bit of red dots that are back there, and that's a result of spinning on a fixed angle centrifuge. Now, there were some nice studies that were performed by Kawazi's group, and instead of looking layer by layer as we've previously done, he did the same thing, but he did it with a membrane. So he took the full-size membrane, cut them up into layer by layer, and then looked histologically at what is actually occurring. And he found the same thing. When you look at a fixed angle centrifuge, he called it very creatively the distal surface of these tubes and the proximal surface. So I thought that was quite an interesting way to actually characterize this. And of course, we reference this work in the textbook. You'll see he showed that when you spin, even with the Lpf protocols, you get a lot of these little dots in brown here, all the cells that are found basically only at the distal surface of these tubes. And that's because you're spinning on a fixed angle centrifuge. So again, when you see these little dots, always remember that the cells, that's because you're spinning on a fixed angle centrifuge. So that's not really recommended. Now, I always say to this day, probably Ganazzi up to this point has done probably the nicest studies with respect to finding proper protocols. But the reality is that when you spin on a fixed angle centrifuge, you can't optimize the results most effectively. So that's issue number one. Issue number two is that, they've looked at typically 3 protocols, and there's a lot to centrifugation to figure out. So we received some funding to do some work where we investigated 24 different protocols from every single individual that enrolled in the study, where we took blood and we spun it at 100G for 3 minutes, 5 minutes, 8 minutes, 12 minutes, 200G for 3 minutes, 5 minutes, 8 minutes, 12 minutes, 400G, 700G, 1000, 1200. And we did these 24 protocols really to figure out where the cells are going, when, at the different protocols. And I can tell you just by looking at this, to the naked eye, you can look at this protocol at 100G for 12 minutes, and this one here at 1000G, for instance, at 3 minutes, and they look the same. The layers look very similar in their separation. But actually, the cells that are found in both these layers are totally different. And that's why it's very important to actually do this basic research to figure out what is the best way to concentrate cells. What is the best way to make an even distribution of cells for a membrane? And this is all work that we've undertaken within the labs before we actually adapted these in clinical practice. So always remember, like I said, those experiments were done with the horizontal centrifuge. For those that want to learn more about how much more effective they are, and like I said, the papers really show they're typically 4 times more effective. You can download some of the publications that we'll make available on the website biopuref.com here. And there's a lot of advantages, like I said, to going horizontal. You get higher growth factor release, more even distribution of these cells, less damage against the back walls there, and of course, less red blood cell accumulation. Now, people that are unsure about fixed angle versus horizontal, because you will hear different people still recommend fixed angle centrifuges. I always say, go to Google and simply do a Google search, fixed angle versus horizontal centrifuges. And these are some websites. You can look at any one of these websites here and look at differences. So I'll go through a few of them. Here, swing out rotors, if you go on this one website, this rotor is particularly useful when samples are to be resolved in density gradients. The longer path length permits better separation of individual particle types from a mixture. However, this rotor is relatively inefficient for pelleting. Okay? So again, if you're going to resolve gradients based on density, which we're trying to do, we're separating cells based on their density, it's much more effective here when we go horizontal. It's not effective for pelleting. Pelleting is better achieved with a fixed angle centrifuge. So what is pelleting? Pelleting is when we want to send all the cells to a bottom of a tube. And that, you see here, this is pelleting in this image. Pelleting means if I have a fixed angle centrifuge, it's more effective, okay? So pelleting means I want to get all these cells down here. So for example, if I'm doing stem cell work in a lab and I want to send all my stem cells to the bottom of a tube in a liquid, I spin on a fixed angle centrifuge, I then remove the liquid, and then I've pelleted all these cells and I can take them out. So if you're a cell biologist, it's very obvious you've done this before many, many times. And for that, we like to use fixed angle centrifuge. And the reason why is that if we use a horizontal centrifuge, if that little stem cell is here and I want to pellet him at the bottom of the tube, that stem cell has to go all the way down to the bottom, and he's got a long path to get all the way there. If it's a fixed angle centrifuge, the cell that starts here quickly, boom, bangs against the back wall, and then slides down to the bottom, and then I can pellet. And what you see right here with the red circle is exactly what's being pelleted there, okay? That's not what you're trying to do with platelet-rich fibrin. And that's what you see actually if you spin and try and make platelet-rich fibrin on a fixed angle centrifuge, a lot of the cells you see actually down there pelleted. And that's where you see them, down at the bottom. So this right here, like I said, this, and it's written right here, this could be problematic if the solids get caught in the angle of the tube. That's what that means. You get caught on that angle. It's not very good for density gradient. Okay, for those, you want a swing out bucket, and it's written right there. Like I said, read online what they're actually made for. And when you see these cells that are banged up on that tube, okay, that's a result of using a fixed angle centrifuge, and reason why we don't use these to separate cells based on their density. Okay, not effective. They're not designed for that. Another advantage that I learned about horizontal centrifuges just from reading online, I remember looking at Drucker Diagnostics, and they had this explanation that we've included in the textbook. Larger radius, higher RCF, shorter spin time. Tube centrifuge and a horizontal centrifuge experience a larger radius, resulting in higher RCF and more efficient forces. Higher G forces produce a better seal with a tube wall due to gel packing. The time required for complete centrifugation is only 2/3 the time required for fixed angle. And I remember reading this and thinking, and looking at the diagram here, if you want to do fixed angle 15 minutes, you go horizontal only 10 minutes. And I remember reading this and thinking, wow, we're trying to separate layers before the tube actually clots. So before that fibrin clot actually forms, I want to separate my layers. I want to get all my platelets to the top and all my leukocytes and all my red blood cells down. And if I can do that faster, it's actually a lot more advantageous than people think using a horizontal centrifuge. Because if I can achieve that separation before it clots more effectively, that's a big advantage, especially for platelet-rich fibrin, because we're trying to separate versus time. We're trying to get it to the top layers before the thing clots. And so that's another big advantage. It's not just that you're saving, 4 or 5 minutes by centrifuging this way here. And of course, we're all trying to save time. So that's great. But more importantly, you're doing it before it clots. And that's where the real advantage is, specifically for Pure F here. And of course, if you look on the Eppendorf website, that's the largest manufacturer of centrifuges in the whole world. Okay, they're the real experts. They're one of the oldest companies that produce centrifuges in Germany. Gradient centrifugation definitely requires a swing out rotor, so horizontal layers can form that remain in this position at the end of centrifugation, okay? Very well known. If you want to separate layers based on their density, you got to go horizontal. So if you're one of these people that have this fixed angled centrifuge, actually consider getting a horizontal one, because of course you can separate these layers a lot more effectively this way here. Okay, and that's basically what was pioneered by our team. We're not the inventors of horizontal centrifuges, and like I said, I always try and make a point that we're just building blocks. There's all these people doing all this work. There's great data from many different teams around the world. We're not trying to say that we're inventing anything new by any means. It's just, if you're actually thinking about this logically, and your goal is to concentrate platelets and leukocytes, then that horizontal centrifuge, which has been around for many, many years and used in a lot of research labs, that's the right way to do it. And I give a lot of credit, like I said, when I look back many years to the works by Bob Marks and his team. Of course, they were using horizontal centrifuges many years ago. And when we had to design this centrifuge, I said, why wouldn't we be using these horizontal centrifuges in the PureF world as well? Okay, so again, that concludes this second chapter, and we're going to go on now and talk more specifically about differences between fixed angles and horizontal centrifuges in the next module.